All right. Good morning, everyone. It's great to see all of you guys. Thanks for joining us for the MVC's first chronic disease management work group of 2023. I'm Chelsea Andrews. I'm the site engagement coordinator alongside Christy, who is also site engagement coordinator for the MVC Coordinating Center. We are joined today also by Erin Conklin, our program manager, and our guest speaker, Karla. So today's work group will feature a presentation by Karla Stoermer Grossman, who is the clinical site coordinator for Inhale, a CQI, which seeks to engage and empower providers across Michigan to accelerate the acquisition of knowledge of evidence-based asthma and COPD guidelines. I'm going to start sharing my screens just so we can go over some housekeeping stuff while we do our introduction. Prior to working for Inhale, she was the clinical care coordinator and certified asthma educator for the Children's Asthma Wellness Program, also known as CAWP, a multidisciplinary clinic at Michigan Medicine, which focuses on high-risk pediatric patients with poorly controlled asthma. She is a nationally certified asthma educator through the National Asthma Educator Certification Board since 2003 and a member of the Michigan Asthma Advisory Committee. She has more than 20 years of experience educating high-risk asthma patients. Karla has a Bachelor's of Arts from Kalamazoo College and a Bachelor's of Science in Nursing from University of Michigan and a Master's in Healthcare Administration from Central Michigan University. Thank you so much, Karla, for joining us today. Before you begin your presentation, I just have some brief housekeeping. We are recording the session, as I stated earlier. The slides in the recording will be shared with all registrants, whether you participated today or not, following the conclusion of the work group. The session slides will also be shared with the link to the work group. We will be monitoring the chat throughout the presentation, so please feel free to add questions throughout the work group. If we see anything on the chat, we're going to just pause Karla from her presentation and she can answer that. And then as well, if you could also, you can also raise your hand if that's helpful. And then after our work group today, we will also have a very brief survey. It's about 5 questions that you could complete just to help us better serve you guys. With that, that is it for now. And I will let Karla share her screen and begin her presentation. Thank you, Karla, so much for joining us again.
Great. Thank you so much for the opportunity to talk to everybody. Let me get everything pulled up here right. So I can advance my slides, hoping everybody can see the slides well now. So thanks again for that introduction, Chelsea. That was it's always interesting to hear like how many years I've been doing asthma for a very long time. I've been doing COPD for less time. So we're going to talk today about Inhale, which is inspiring health advances in lung care. And we're going to be focusing on the guidelines, both for COPD and for asthma. My objectives today is, again, to discuss the background rationale for why Inhale was developed and review the overarching goals of the statewide CQI. Review asthma and COPD basics and explore asthma and COPD updates in their guidelines. I want to thank MVC. Our partnership with them has been absolutely invaluable. They share claims data sets with us. They've developed COPD reports, which we have then shared with our physician organizations. We're discussing ED episodes of care and figuring out how we can do that and get more information on that, and a lot of technical assistance. And so we really, really appreciate that. And a lot more than just is on this slide, but it's just been invaluable, our partnership with them. So why asthma and COPD? Why do we have a collaborative quality initiative focused on asthma and COPD? We have really great guidelines. This is showing the GINA guidelines, which is the Global Strategy for Asthma Management and Prevention, which is an international guideline. They're updated yearly. I'll go into that a little bit more. And we have the asthma management guidelines from the NAECB, which is a National Asthma Education. I always forget what the 2 Ps are for, but it's run by NHLBI, which is the National Heart Lung Blood Institute. And those are our US guidelines. And then we also have the GOLD guidelines for COPD, which is again is an international, but is the gold standard for COPD care. So we have multiple medications. We have tons of medications. We have these great guidelines, but we still have a lot of problems. We still have lots of things that need to be taken care of. We've been using short-acting beta agonists, which is our rescue or reliever medications, since 1981, and we've had other medications since 1956, like oral prednisolone. And more recently, we've had tons and tons of biologics come in, but we're still having problems. In Michigan, we still have an adult prevalence rate of 11.1%, and we rank third in the nation. We are also considered now, Detroit is now considered the #1 most challenging place to live with asthma in Michigan, and in the entire nation. So Michigan is now #1 worst place to live with asthma. And we do also have a really high prevalence of COPD in Michigan. We have the prevalence rate is 8.5% with about 647,000 individuals living with COPD in the state. We also have some very major racial disparities in asthma and COPD mortality. You can see here with mortality with chronic obstructive pulmonary diseases are about 800 deaths in 2019 and 132 deaths in 2020. So we have a problem. So what are we going to do about it? INHALE, which again is Inspiring Health Advances in Lung Care. We were asked by Blue Cross Blue Shield to put together a collaborative quality initiative that works with PDSA cycles, both at the local, like the provider level, and at the state level. And we put together a group of content experts with Dr. Najira Lagogo as our program director, Michael Schoding as our program co-director. We have content experts of Dr. Romel Sagana, Dr. Gary Freed, Anna Kowalski, and Dr. Toby Lewis. And then we have what we call our coordinating center with Courtney Oliver being our program manager. You can see myself there as a site coordinator, Don Zinser as our data analyst, Kelly as our admin assistant, and Brenna Dressler as a health educator. So this is our team. So what are we supposed to do? Our content experts came together and looked at the guidelines and came up with these 5 sort of pillars of direction. We want to identify the prevalence of uncontrolled asthma and COPD in the state, which I've sort of already outlined for you. Increase compliance with guideline recommended assessments of control. As we said, we have really good guidelines. Improve the quality of care based on adherence to these guidelines. This is where we're kind of slipping on things. Increased knowledge of phenotypic characteristics of asthma and COPD. Let's get more into the weeds of why and how and making sure the right medications are getting out there. And we want to increase tobacco cessation counseling and interventions. We're doing this in collaboration with, that should be HBOM, which is Health Behaviors of Michigan. So purpose, Chelsea kind of brought this up in the beginning, but the Inspiring Health Advances in Lung Care is a collaborative quality initiative in partnership with Blue Cross Blue Shield of Michigan that aims to engage and empower primary care providers, specialists, and physician organizations across the state to improve patient outcomes, address inequities of care, and promote high-value health care for children and adults with asthma and adults with chronic obstructive pulmonary disease. We are the only CQI in the state that's focusing both on pediatrics and adults. So what are our targets? We have the QI targets for asthma and COPD are diagnosis, control, risk stratification, short-acting beta agonist over-reliance, and oral corticosteroid overuse. So we kind of need to look at this both at the participating health systems, the PPOs, the practices, and the providers, and then also from a patient and caregiver perspective. So we want to make sure we're addressing all of those things. Our initial initiatives will be around spirometry, patient education and tobacco counseling, utilization and medication over-reliance. This is probably more details than you guys are interested in, but we'll be looking at creating measures on each of these things so that we can measure the physician organizations and practices and help them create PDSA cycles and change. So let's get into the details. This is where we're all very, very interested in. What's new in asthma? I wanted to go first just the basics to make sure everybody is on the same page with the definitions. Asthma is a chronic inflammatory disease of the airways characterized by recurrent episodes of wheezing, shortness of breath, chest tightness, and coughing. The real important part of this is that the airflow limitation is at least partially reversible, meaning we can make it get better. this all happens in response to triggers. So they get airway inflammation, bronchial smooth muscle constriction, which is that bronchospasm or squeezing, and increased mucus production. The airways become narrow and breathing becomes difficult. I always talk to patients about the 3 S's of asthma. There's squeezing, swelling, and snot, essentially. So we have the swelling causes more squeezing, so you have less, the flow of the air can't get through the tightened up airways. And then you also get this production of mucus down into the lungs, which also causes it to be more difficult to breathe. So, but these symptoms are just the tip of the iceberg. At the bottom, as I said, we have this airway inflammation, bronchial hyperresponsiveness. It means things, your airways are twitchy, they squeeze more often, and there's this airflow obstruction. When we talk to patients, of course, it's really hard to think about what is actually going on in our lungs. Sometimes with the pediatrics, they don't even know where their lungs are. So we kind of start with that. Where are your lungs, right? They always point to their bellies because that's what you see going up and down sometimes. But when you talk to even to adults about where your lungs are, we rarely have a full picture of it, right? So this is a good visual of what's actually going on. So on the one side, you can see here that there's the what we're calling the normal lung. This is a nice open space where the air can move in and out very, very freely. So if you take a deep breath and you blow it all out, it flows through nicely. You're not getting any weird sounds. You're not coughing. But with an asthmatic lung, during an exacerbation, you actually have these muscles on the outside of the tube. If you can look on the other side there, this is asthmatic lung. These muscles tighten. So you have a tube that started out like this, and now it's already squeezing. And on top of that, there's swelling inside, so even smaller space. And then you get this mucus and production also. So you can see that it could lead to a lot of problems breathing. You can also see at the end of those tubes, you can see kind of like a bunch of grapes at the bottom. That's the alveoli. That's where the oxygen transfer happens. And if you think about breathing, we breathe in, you have this muscle that your diaphragm that pulls all the air in, but the exhalation or the breathing out is actually a matter of relaxation. And so you can pull air in, but you can't let air out because it can't get past that swollen and squished up air tube. So then the bubbles at the end, the alveoli actually get hyperextended. So this is where you have the air trapping. This picture shows things really nicely. On the far left, you have the normal airway. In the middle, this is the asthmatic airway. Someone could be living with this and not even know that they have asthma. On the right, on the farthest right, that's where you're going to have this asthmatic airway during an attack or an exacerbation. You can see what the person is more likely to have more symptoms. The airway in the middle could be someone that's living with an everyday life, but that could be very close to having exacerbation at any point in time. So what do we do about this? I mean, obviously, this is not, maybe not so obviously, but obviously to me, and hopefully to you all, that this is something that we don't want to live with. We don't want to live with the risk of having a severe exacerbation that could lead to death, actually. So what do we need to do? Again, we said we have great guidelines. In the NAECB 2020 focus, that was that middle guideline I was talking about, and that's the guideline from the US. They have a full guideline that was written in 2007. And then most recently, they had updates that we're calling the 2020 focused updates. They only focused on 5 key questions listed here: the FeNO, indoor allergens, adjustable medication dosing and recurrent wheezing and asthma, long-acting muscarinic antagonist in asthma, Xolair, and bronchial thermoplasty. And these were based on studies in 2018. I'm giving you these dates to let you see that they're older guidelines. They haven't been fully updated since 2007. Whoop, sorry, I don't know what happened there. The GINA guidelines, the Global Initiative for Asthma, is a report and guidelines that's updated every single year. There's a twice yearly cumulative review, and it's now considered by many to be more of a gold standard than the NAECB, even in the US, just because it's updated more frequently. So, but there are some differences. We're all sort of working between these 2 guidelines right now for asthma. In the NAECB guidelines, there's 6 steps for treatment. In Global Initiative for Asthma, there's 5 steps. The age ranges are just a wee bit different, which makes things a little complicated. In the NAECB guidelines, there's 0 to 4, 5 to 11, and 12 and older. You can see in the GINA guidelines that's just shifted just a bit to be 5 and younger, 6 to 11, and 12 and older. And you're probably saying, why is that important? It is important when we're trying to move between the two guidelines and decide which one's best for our practices. In the NAECB, intermittent asthma is separated from mild persistent asthma. It's considered a different step. And in GINA, this is really important. They combine intermittent and mild persistent because they're seen as equal risk. I'll talk about that in just a few minutes, a little bit more. And you can see that the focus on short-acting beta agonist, which is that SABA in NAECB, is much greater than it is on the GINA side. So what's happened? There's been a real paradigm shift in asthma care. GINA no longer recommends treating adolescents and adults with asthma with short-acting beta agonists alone. That was in the NAECB guidelines. Those would have been, and in GINA previous to 2019, those would have been those mild or intermittent asthmatics would have only the short-acting beta agonists, drugs that you think about like albuterol, Proventil, ProAir. They say instead that you should receive symptom-driven or daily corticosteroid-containing inhaler to reduce the risk of severe exacerbation. So every person, GINA is saying, should have an inhaled corticosteroid. So why not treat with short-acting beta agonist alone? This kind of goes back to how we first started thinking about asthma. We really thought 50 years ago that it was truly just a disease of bronchoconstriction, just the squeezing part, not the swelling. We had no understanding of the swelling part, actually the underlying problem of asthma. But now we know that even patients with infrequent symptoms have airway inflammation, and they would benefit from inhaled corticosteroids. If we just focus on the reliever, it trains the patient to regard it as their primary asthma treatment instead of taking a controller medication. And the only previous options for ICS in inhaled corticosteroids was daily use, even when no symptoms, but adherence is extremely poor. Even in really controlled settings, the adherence rate to daily controller medications in asthma is about 40%. So it's really, really not great. So both GINA and NAECB changed the recommendations once evidence for safe and effective alternatives were available. So we are moving forward. So we hopefully will be moving away from patients that have short-acting beta agonist alone without the support of the inhaled corticosteroid. GINA also does not distinguish, as I said before, between an intermittent and mild persistent, because this historical distinction was arbitrary, which I was flabbergasted when I read this, that they just this was just an assumption. And based on the untested assumption that patients with symptoms twice a week or less would not benefit from inhaled corticosteroids. However, these patients are still at the same risk as severe persistent asthmatics of having a severe exacerbation. So we really do need to treat them with inhaled corticosteroids. So this goes into a little bit more just the fact that we need to have ICS containing treatment, and it's recommended for all children 6 to 11 years older with asthma, either regularly or in mild asthma, or taking ICS whenever a short-acting beta agonist is taken. So again, we don't want to have short-acting beta agonist alone. We do know that dispensing more than 3 canisters per year is associated with higher risk of a severe exacerbation, which kind of makes sense because you're using the albuterol as a rescue or as a reliever, so something is going on. So if you're using more than 3 per year, you're at risk of having a severe exacerbation. And dispensing more than 12 canisters per year is associated with much higher risk of death. So this is a big deal. And I think a lot of doctors have changed their practice, but back when I was started working in asthma, it was really common for doctors to give 11 or 12 refills on their short-acting beta agonist on the albuterol, and maybe 3 refills on the controller medication, which gave the wrong message. In fact, they did that with me. They gave me 11 refills and only 3 refills on my inhaled corticosteroid medication. I have asthma. And that messaging was that they were trying to tell me that it's really important to have a rescue inhaler with you at all times. But the message wasn't coming across that you need to take your controller every single day. So it was really super easy to get your short-acting beta agonist, but it was harder because you had to call more frequently to get your inhaled corticosteroids. So the messaging was a little bit backwards. Also, with short-acting beta agonist, regular use, even for 1 to 2 weeks, has been shown to result in actually the opposite of what we want to have happen. It results in poor asthma control. There's a downregulation of the beta receptors, and there's a loss of bronchoprotection. There's enhanced exercise bronchoconstriction. There's rebound hyperresponsiveness. None of this stuff sounds good, right? It's going to actually make your asthma worse. You're going to have decreased bronchodilator response. At some point in time, it's not going to work any longer. And there's enhanced eosinophilic airway inflammation. So more inflammation caused by taking the medication that's supposed to stop you from having an exacerbation. And then also, if you're using more short-acting beta agonists, meaning you're not well controlled, you're going to be having more and more oral corticosteroids, which are actually really bad for you. We kind of toss them out like candy. I know that in our clinic, in our severe asthma clinic, we had patients that came to us regularly that had already had in their young lives 6 to 8 oral corticosteroid bursts per year for multiple years. Okay, so think about the cumulative dosing of that. And we've now found out that a cumulative lifetime dose, not just a year dose, of 1 to less than 2.5 grams of oral corticosteroids significantly increases the risk of adverse outcomes such as heart failure, heart attack, cerebrovascular disease, type 2 diabetes, cataracts, glaucoma, pneumonia, sleep apnea, depression, peptic ulcer, renal impairment. These are big deals. We throw oral corticosteroids out because they work, but it's like calling the fire department for a tiny little house fire, not house fire, little like kitchen fire. So we really need to think about how we're using our drugs. It's much better to use an inhaled corticosteroid, which is in micrograms, then you want to have an oral corticosteroid, which is in milligrams. So one 3 to 5 day dose of or burst of oral corticosteroids is equivalent to a full year's worth of inhaled corticosteroid. And when you use an inhaled corticosteroid, most of it's going to your lungs, whereas oral corticosteroids obviously are affecting all of your organs. So we have this paradigm shift again, and it says that every adult and adolescent should have an ICS containing controller medication, and that we should have a reliever inhaler for as needed use, either low dose inhaled corticosteroid formoterol, which we'll talk about a little bit more, or short acting beta agonist, but it should always be used with an inhaled corticosteroid. So this is the big change, and this change came across with both NAECB and GINA. GINA uses it a little more extensively than NAPP, excuse me. It's called single maintenance and reliever therapy. It's using as needed low dose ICS formoterol, so the inhaled corticosteroid formoterol in adolescents, adults, as both of these are daily medication as the rescue medication. So you have one inhaler that you use for both things. They've found that this reduces the risk of exacerbation as compared with as needed short-acting beta agonist. It's similar or lower risk of severe exacerbation. There's less ED visits and hospitalizations, and can be used in exercise-induced bronchospasm and pre-treatment for activity. So let's look and see how this plays out. There's reduced exacerbations. There's reduced severe exacerbations, reduced corticosteroid associated adverse side effects, improved asthma control, improved quality of life, and there's no risk of compared to previous recommendations. Now, there are some other considerations. There's lower risk, which is a good thing, lower risk of growth suppression that can happen with inhaled corticosteroids. But there is insurance costs. There's insurance issues. Inhale has worked with the major insurers across the state to make sure that the use of these medications will be covered. So there shouldn't be formulary issues, but there could be some formulary issues with some of the smaller insurers, because 1 month's supply may not last if used for reliever. So if you get one inhaler and you're using it for both things, you might go through that inhaler more frequently. There could also be a medication intolerance. So how does GINA approach this? In the 5 years and younger, you'll notice that the reliever medication here is the as needed beta agonist, short-acting beta agonist. I should talk about just how this is all set up. I'm sure we're all pretty familiar with how NAECB is set up, looking at the risks and the spirometry, and it has these step therapies also. They're put together a little bit differently than this, but it's pretty close. You can see at the top there's step 1, step 2, step 3, step 4. Those as you go up your severity classification are the medications that would be recommended with those severity levels. And then there's 2 on the preferred controller choice on the far left, there's 2 tracks. The first one is just the preferred controller choice is what I've shown here. So the reliever just for kids for 5 years and younger is just the short-acting beta agonist. And you can see that the other medications are inhaled corticosteroids and none of our combined medications that have both inhaled corticosteroids and long-acting beta agonists. The ages 6 to 11, you can see at step 1, you take the low dose ICS taken whenever short-acting beta agonist, the short-acting beta agonist is taken. So if you have a cold, so you wouldn't be taking something every single day. This feels closer to our like intermittent asthma from the previous guidelines. But you would add this low dose inhaled corticosteroid every time you take a short-acting beta agonist. So you have that protection of that steroid working with that inflammation that's in your lungs. This is where step 3 and step 4 is where you get into this, what was called SMART therapy, the single maintenance and rescue therapy. You'd use a low dose inhaled corticosteroid, long acting beta agonist, and as both controller and as rescue. So this is where there's the big changes from what we were doing previously. And you can see that you would still use the as needed short acting beta agonist in those first steps 1 and 2, and then or add the ICS formoterol taken as the maintenance and rescue therapy in steps 3 and 4. In 12 and older, this is where things really get, I think, really almost easier to do. Because in the step 1 and 2 there, you see that you're going to use as needed low dose ICS formoterol every single time that you use, if you have a problem. The neat thing about this, and I guess someone that's only people that are truly interested in asthma and care of asthma think it's neat, but the steps that this is actually having the ICS and the formoterol. The formoterol, which is the long-acting beta agonist, lasts 6 to 9 hours versus the short-acting beta agonist, which only lasts 4 to 6 hours. So you can actually get longer control, a longer opening, relief from that bronchoconstriction by using this medication with less risk. And you have that controller medication, that ICS on there on board to help also. So by using the ICS formoterol, you'll actually use less medication in the long run. Again, this reliever is also the as needed low dose ICS formoterol for all steps. Obviously, between steps 1 and 2, it already says the as needed low dose, so you're not going to, it's the same drug there. And there is an alternative reliever for other people. If you feel that this person is not going to be as adherent with taking medications, there's other directions on who would be recommended to take the controller and alternate reliever, which that alternate reliever would be the short-acting beta agonist. So short-acting beta agonists are still going to be in use, but they're going to be used at all times with an inhaled corticosteroid. So how do you do this? There was a really great article in the JACI 2022 of January, a practical guide to implementing SMART in asthma management. And they really stepped through this. It's a great article to read about how do you actually do this in practice. And the target population would be 5 years and older. And the patients that are not well controlled on ICS LABA with PRN SABA, and that's inhaled corticosteroid with long-acting beta agonist with PRN or as needed short-acting beta agonist, should try these things before stepping to a higher inhaled corticosteroid. We want to make sure that we keep the inhaled corticosteroid at the lowest level that we can control their asthma with, because that inhaled corticosteroid is where you're going to get those potential systemic side effects like growth retardation or slowing. So you do not ever want to use, you can only use SMART with drugs that contain formoterol, which is a newer long-acting beta agonist. You probably know Symbicort, Dulera. You might have heard of those in those commercials. There's also a generic budesonide formoterol drug also that can be used with, but it can only be used for formoterol. It cannot be used with any of like the long-acting, the super long-acting beta agonists because there's it's not considered safe. So you can use you cannot use ICS and salmeterol as SMART. There's a slower onset with the salmeterol, and there's a flat dose response with that. So it will not be effective, and it can be actually dangerous. So this talks about how to use it in every single day. There is a maximum number of puffs per day that's considered the control plus rescue. 4 to 11 years, you'd have 8 puffs total for the full day. And in the 12 and older, 12 puffs total. So you would still use your inhaler in the same way that you'd use your short-acting beta agonist. 1 puff every 20 minutes is needed. But you're going to end up in the end, according to the studies, you're going to have less use of that medication because that long-acting beta agonist lasts longer. This is to go quickly through assessing control and how to step up and step down. You'll get these slides, probably don't need to be talked about right now. So we need to move on to COPD. So COPD is chronic obstructive pulmonary disease. It is a heterogeneous disease of the airways characterized by chronic respiratory symptoms of dyspnea, so shortness of breath, cough, sputum production, which is different from asthma, and activity limitations. These abnormalities are in the airways and or alveoli, which you can see in this picture previous, and are from bronchitis, bronchiolitis, and emphysema. And it results from gene environment interactions over a lifetime, including exposure to tobacco smoking and inhalation to toxic particles, indoor and outdoor pollution. The highlight difference between asthma and COPD is that it's persistent, often progressive, and there's a airflow obstruction that is not fully reversible. So again, in asthma, that airway is reversible. There is now something people are calling, asthma, COPD overlap, and some other terms that is sort of this movement of I'm an asthmatic, that my airways are starting to get scarred, and or I've got these toxic interactions like smoking, and that's leading me to become more like a COPD patient. And we'll talk about that just really briefly. So again, we have super guidelines, right? We have these gold guidelines that are updated every year. And they go very specifically and step by step on what to do. So I'm going to review these step by step. So again, the clinical indicators for considering diagnosis is that we have this dyspnea, this shortness of breath, that's progressive over time. It gets worse with exercise, and it's persistent. This cough may be intermittent and maybe unproductive. So again, how do you determine this difference between asthma and COPD? We also have these history of risk factors. There's tobacco smoke or smoke from home cooking and heating fuels, occupational dusts and vapors, gases, and other chemicals. So there's a lot of other things that could be happening, and we have a lot of exposures. So this kind of talks about that differential diagnosis. In COPD, the symptoms are slowly progressive, and there's a history of tobacco smoking or other risk factors. In asthma, there's variable airflow obstruction. Sometimes it's completely normal. Actually, lots of times it's completely normal. Symptoms widely vary from day to day, and sometimes they get worse at night or early morning, because this is our cortisol levels that affect how our lungs work with our own corticosteroid or steroid kind of exposure in our own bodies, protective. And then there's this allergic kind of component also. The goals of initial assessment, we're going to determine the severity of the airflow obstruction, the impact on the patient's health status, predict the risk of future events, and then guide our therapy. I'm sorry, in asthma, I didn't really talk about how to do the diagnosis. We were talking more about the treatment. And this time, we'll talk a little bit more about diagnosis. The fact that forced spirometry, that demonstrates a post-bronchodilator effect of greater than 70% on the ratio, which is the FEV1 to FVC, is mandatory. The spirometry is mandatory to establish the diagnosis of COPD. Spirometry is very useful in asthma. We use it to check in to see how things are going and how much obstruction is still there. But in COPD, it's actually mandatory to do that testing and to get those results in order to give the diagnosis of COPD. They have these levels, gold 1, 2, and 3, 4, that is predicated on the actual results you get of that FEV1. That ratio. So it's very important to get that testing. Actually, it's crucial. This is this pre-COPD or PRISM that I was mentioning before, that you could have patients that have respiratory symptoms, may have normal FEV1, but they have gas trapping, hyperinflation, and a rapid FEV1 decline, but their ratio may still be over 70%. But these people are at risk of developing COPD, and some of our data results are actually showing us that they are very high utilizers and have a lot of problems. So there's an at-risk population that we really need to start paying more attention to with early diagnosis and intervention, because we have this opportunities for preventions, like by stopping smoking, we could stop the progression of this disease. Early. So we also have these patient-reported outcomes, which are really crucial in the treatment of COPD. They are the two tests that are recommended are the modified MRC dyspnea scale and the CAT assessment. If you look at this, they look at what is the patient actually experiencing on a day-to-day basis. Like a question of, I walk up the hill or one flight of stairs, I'm not breathless, or I am very, very breathless. So it's how is this impacting you on an everyday basis? We take this and add that to your spirometry results, and you come up with, and you add that to your exacerbation history. In the center, you can see spirometry confirmed diagnosis, assessment with airflow obstruction, so that puts you in a grade. And then you have your exacerbation history. So do you have 2 or more moderate exacerbations, or 1 leading to a hospitalization, or 0 to 1 moderate exacerbations not leading to hospitalizations? Once you get that assessment of symptoms and risk of exacerbations, because you can see at the bottom there the symptoms, you get this grid. And you make a choice of, let's say you have a patient that's been hospitalized, so that automatically puts you up in the E level, and regardless of their symptoms, their actually perceived symptoms. But if you have a patient that's only had, like, let's say, no major exacerbations, or let's say 1 moderate exacerbation, but they're not feeling a lot of symptoms, that would put you in that A classification. If they've had, but maybe they have a lot of symptoms, maybe they're feeling a lot of dyspnea or have a lot of sputum production, that would put them in the B classification. So again, you take the spirometry results, the personal feeling of what's going on, and then you take their exacerbation history, and it puts you in a classification, E, A, or B. And then this will help you walk through what medication should that patient be on at that point in time. So let's talk about that patient that we said has had 0 to 1 moderate exacerbations. So you look at that left lower box, and let's say that they have a score that shows them that they're not having a lot of symptoms. That grade A patient would be using just a bronchodilator. If you have, again, if you have more symptoms, you're going to use a long-acting beta agonist plus a long-acting muscarinic antagonist as a combination drug. And then also same with the patients that have had the LABA-LAMAs. I always call them LABA-LAMA, which is a fun to say. So the LABA-LAMA at the top there also, that note of you should consider having an ICS in there if your eosinophils are greater or equal to 300. So this is pretty, I think it's pretty concise. You're able to walk this through pretty easily. This is talking about that ICS part, that top in the E, when you should be using inhaled corticosteroid. I know that a lot of in the older days, maybe even 5 years ago, we were putting a lot of COPD patients on to inhaled corticosteroids, and they're actually showing that this puts them at higher risk of pneumonias. So you have to make sure that you have to have the right patients on that. strongly favors use, and against usage. So again, that repeated pneumonia events, their blood eosinophils are less than 100, and they have any history of mycobacterial infection. But strongly favors is they've had history of hospitalizations for COPD. They've had blood eosinophils over 300, and they also have a history of concomitant asthma. So again, ICS is not used as frequently now, which is a paradigm shift. So once we get these, we get them on the right medications. So what do? We've moved through this management of COPD. We've looked at their symptoms, their risk factors, their spirometry. Again, that we needed that for both for confirmatory diagnosis and then also tell us which step they're on. We've done our initial assessment. We've done our initial management, which we didn't talk about very much, but it is that smoking cessation, vaccination, because we don't want people to get infections, active lifestyle. You need to stay active. You need to get exercise in order to keep that lung health going up. There we have our initial pharmacotherapy, which we just reviewed. And then there's a lot of self-management education, including inhaler techniques, which we'll talk about both for asthma and COPD, but very, very important. A written asthma action plan, which we typically think of just for asthma, but they have them for COPD also. And then we need to manage our comorbidities. We're going to review at all our visits. There are symptoms, our exacerbations, smoking status, exposure to other risk factors, inhaler technique, and all of those other steps. And we're going to continue like a PDSA cycle, review, assess, and adjust. This steps through the type of pharmacological treatment that you should be looking at. If you're responding to the initial treatment, they put you on with that A, B, and E, you're going to continue with that. If not, we're going to check, first of all, you always need to check adherence. Are they actually taking the medications? As I mentioned with asthma, with only 40% adherence rates. I don't know those rates for COPD, but it would not surprise me if they were almost exactly the same or maybe even lower. And we need to consider if there's other things that might be there's insurance issues and other things. We'll talk about that in a second too. We're going to put them in a box corresponding to the current treatment, and then follow that through. So this is a nice algorithm to show like where you should move things through. If you have a lot of dyspnea, you've been on a LABA or LAMA, you should consider switching inhaler device or molecules, implementing or escalate, investigate and treat other causes of dyspnea. There's other things you could be using, antibiotics. You can see azithromycin that actually has some anti-inflammatory effects on the lungs, and other drugs there also. Then this follow-up their non-pharmacological treatment. I think this is where a lot of us care managers and nurses can help a lot, and social workers. We really need to, push for those flu vaccines every year, make sure that they get the pneumonia vaccines, self-management education. How do you work this into your daily schedule? Also making sure that those inhalers are being used appropriately with the right techniques. And also the smoking cessation is just a really big thing. Exercise, physical activity, healthy diet is really important. There's a lot of can be a lot of weight loss, and puts you at being more frail and at higher risk of exacerbations and death, the more frail you become. Pulmonary rehab, this is another thing that we'll be focusing on with Inhale, is very, very important. It can be really almost life-changing for patients. It won't necessarily change their spirometry results, but their feelings and quality of life will improve, and their ability to move and do more activities is really increased. And we have very, very low rates of pulmonary rehab currently in the state. Not at places to go, but actually using it. So from a patient perspective, to follow the time here, it's can be really complicated. I mean, I flew through all of this stuff. These are just a really high view of the guidelines, and taking your patients' lives into consideration. What do they do every day? If you've got, is it a small child? Is it an adult? Is it an adolescent who doesn't want to take their medications, who doesn't think they need to take their medications? It can be really complicated. I also share this slide just because it's fun. This is at a dive meet of my youngest daughter. She's the one upside down and angled off the 3-meter in the background there, as this young man is, I don't even know what he's doing. I think he's trying to do a front flip and is just kind of crazy. So it just reminds me of the chaos. There was diving going on. There was people flying through the air in all these different directions. And that kind of feels what it feels like to help patients sometimes with all of their multiple problems or challenges in their lives with getting insurance and other coverages, and learning how to use the devices appropriately, which device do you use at which time, and as it can get very, very complicated. So we always want to remember that you need to remember adherence, because if they're not taking their medications and you're only looking at the fact that they're not well controlled, you might add other medications when you really need to just focus on the importance of taking that medication every single day and figuring out how to help them do that. Device technique is really easy to do badly. You can see in this picture here, there's actually a dry powdered inhaler, the Pulmicare FlexHaler, attached to a chamber and a mask. There's no way that anybody's getting medication out of this device, because a dry powdered inhaler should never, ever, ever be used with a chamber. Insurance coverage, as you know, especially with Medicaids, it's gotten a little better with a Medicaid common formulary, but those formularies change all the time. There may be high copays, there may be restrictions on age, there may be restrictions on how often you can get it. There's also environmental triggers that a lot of people don't have control over if they live in like public housing or an apartment or even their own home. There might be mold or other things that can be causing problems. And then tobacco use, which we all know is a very hard thing to quit. So I wanted to talk a little bit about choosing an inhaler device. And again, on the far left side, we talk about adherence, affordability, triggers, device preferences. And then we need to think about, does that person actually have the capability of doing a device on their own? Because it can be, what about a 2-year-old or someone that is older that maybe have some cognitive function or cognitive decline? So we can step through these steps. We also make sure that they can actually use the devices. Can they use their fingers in a way that can actually make the device give the medication? And then we also have to talk about how can they take a deep breath in and hold it. So this is some of the tools that we're putting together through Inhale to help providers create or decide on a medication that will be best for their patients. Looking at my time a little bit over, so I think I've flown through that very quickly. I want to thank you everybody for attending and listening. Here's my contact information. Feel free to contact me if you have any questions or thoughts. And I did put in extra slides at the end, just some other resources that can help work through these guidelines. And I want to share those also. And those, I know that those we made available when they're shared with everybody. So I just wanted to review those really quickly. Some other things that we have available for everybody. And that is the end of my show. Appreciate everybody and your time. Is there any questions that I can answer right now? Or if not, you can feel free to contact me later or contact, I'm sure, Chelsea or one of the other MVC people, and we can get those resources to you or questions answered.
Wonderful. Thank you, Karla. Are there any questions from our group today?
We're going to be creating we're calling it a learning platform that'll have a ton of resources, both for asthma and COPD available on it. It will also have CME opportunities and a lot of educational materials all in one spot. So if people are interested in having access to that, they can also contact me and we can make sure that that starts happening. That will be available hopefully by the first or second week of February. Yes, the slides, my understanding, the slides will be sent out to everybody.
Yes, correct.
I'm sorry, again, we went through this really quickly, and I really appreciate you for just staying and listening. And again, I'll be more than happy to answer any questions now or later.
This was really valuable. I have two questions. My first question, I know there was a lot in the asthma section about using like Symbicort or the combination ICSs. What about like the single? I know there's a lot with like only Pulmicort, which is just the budesonide, or I can't recall how it's said. What is the research on that, or how does Inhale approach that with patients?
Well, so it's still a what we would it's still covered in the alternative therapies for like the older group. So in that 12 and older, which they're really pushing smart therapy, if you feel that your patient is, if they're well controlled already on, let's say, a single controller and short acting beta agonist, there's no need to change them if they're well controlled on that format already, because changing is difficult for patients, right? Maybe the device is different, their coverage may be different. So if they're well controlled on their current therapy, it's okay to stay that way. Now, if it's patients not well controlled, instead of adding more inhaled corticosteroid to that, and this is the same with the NAPP guidelines from the previous guidelines, you don't just add another level of inhaled corticosteroids, you don't go from like 100 to 200, you would add a long-acting beta agonist first before stepping up. So that's the slide over versus the step up, which was mentioned in the NAPP guidelines from 2007. But the long-acting beta agonist use in GINA is even more prevalent, meaning that you should start on a ICS combination drug, which is different from all of our previous knowledge of working with just an inhaled corticosteroid with a low dose. But those were always separated from the ICS and the SABA were always separate things, right? You took your ICS every single day and you took your SABA maybe multiple times a day, but not with inhaled corticosteroid attached to it. So it really is looking at the fact that short acting beta agonist, as we talked about before, can cause actually more exacerbations. So this is the long acting beta agonist lasts longer, so you're going to be using less. It also doesn't cause that like eosinophilic hyperreactivity and other the negative side effects of the short acting beta agonist. So yes, we still have all of those drugs, but it's the ICS LABA is kind of getting that highlight now of being. It used to have a black box on it. The long acting beta agonist part of it did. That was there because they were doing studies with long acting beta agonist alone without ICS, and people actually died from that because they weren't taking care of that underlying problem of the inflammation, right? Because again, we're going back to that old school thought of it was just bronchoconstriction, but it actually is hyperinflation. It is inflammation causing the airways become hyperreactive. So we need to take care of that base problem, that base of that whole iceberg there of the inflammation first. So yes, it's still possible to use that. That's absolutely, but it is now the leanings in both actually. The 2020 updates also talks about using SMART in children. Actually, they go younger, 4 and older, but only for that step 3 and 4 for moderate asthma versus the step 1 therapy in GINA for the older people.
That's really helpful. Thanks, Karla.
Yeah.
My other question was, how easily accessible are these, these guides, resources for both providers and patients?
So the NAPP guidelines and the GINA guidelines are both available on the web. Very easy to research. If you just looked NAECB asthma guidelines, it'll come up with everything. There's a great clinician's guide, which I have on the back of my slide, in the end of my slides, that walks through, so you don't have to read the whole document, which can be, some of them are hundreds of pages long. There's an overview that's really good. The GINA guidelines are also available, and they have what they call a pocket guide. So it goes through like the highlights of everything. It also has what's new slides that are very useful. The gold slides that I actually showed are from those gold update slides. I took them straight from the deck. And so that's why I have the copyright and everything still on them. I did do a little updates to them or combine a couple things, but all that data is directly, or all that information is directly from the gold guidelines. So I think they're very accessible, and you can get them printed out also, but they're fully accessible online.
Great, thank you.
Yeah. And as I said, we're calling it Inhale Learning platform. We'll have all of these available, and we've created, and I've shared some of those in the slide set, some we call cheat sheets or little infograms that takes all of these guidelines and puts them into one page so you can make better decisions for each age group.
I have a follow-up question as well, if you don't mind.
Oh, absolutely.
So if If someone was admitted to a hospital for exacerbation of COPD or asthma, have you found that there's any commonalities between people being readmitted afterwards, like looking at readmissions? Are there factors among the people for having to be readmitted?
I haven't done as much research on that. As I said, COPD is a little newer for me. I've been really deep end in asthma. I do know that we are doing some looking at the data for those patients. And we'll be doing a little bit of chart abstraction with the charts that we have access to, looking at what is actually going on. I do know that the older you get, the more severe your asthma is, and if you especially like tobacco cessation. But I do know, like at our own health system, they've done a lot of work on teaching how to do the devices, because I know that wasn't a lot of the patients were coming in without knowing exactly how to use their device, or were using it improperly. And it's I want to say very easy to do improperly, but there's 5 steps that you should make sure that's happened every time. And so really honing in on that inhaler education is really important. That's why that is one of our main focuses for this coming year for us, is actually how to use the devices, and thinking about those special populations like the older folks, maybe with arthritis. And that's why that slide with checking the cognitive function, are they able to do it, or do they need to have support to do it? Everybody says, oh, just slap them onto a nebulizer. Well, nebulizer is actually pretty challenging to set up, and you also have to have a lot of manual dexterity to open up the ampules and pour it in and put it all together. So, just saying, oh, you can just use a nebulized therapy, that's easier to breathe. But there's also issues with, which we talk about on our Inhale website. We have a CME around this, that the droplets are bigger. So you're actually losing a lot of medications on your face and other places and in your airway. So a lot of the medication's actually not getting down into your lungs. So maybe a metered dose inhaler with a spacer and with a mask would be better for an older adult that has, arthritis and some respiratory problems, or not respiratory problems, but cognitive issues. You could have someone help them with that. And there's less breathing coordination issues. And then there's also the fact that you'll get more medication deposited into the lungs, so you have better results. So I think inhaler education is the base of all of this. If we don't have, first of all, selecting the right inhaler, and then teaching them how to use that inhaler appropriately. When I was given an inhaler in college, I was literally handed a box and essentially said, good luck, have fun. It's like I had to read the insert, and reading that without any medical background can be confusing. And then often cases people are given an inhaler without a chamber. A chamber for metered dose inhalers is really, really crucial. You get about 80% more medication down into the lungs with a chamber, whereas by just pressing it out into your mouth, you're going to get a lot of it just stuck in your mouth or into the back of your throat, because the inhaler, it really sprays out a strong spray, even the HFAs, the new ones, and it goes a long way. And if you think about that being in your mouth, it's going to spray and hit the back of your throat before it goes down. So you lose a lot of medications that way. And as I said, you get about 80% more medication if you use a chamber. But how often do adults get chambers? Not very often. So we're really advocating for more use of the chamber. And then also we're advocating also by looking at, there's a CPT code for inhaler education. So you can get paid, your office can get paid for using this 94664 code for inhaler education. And then you should be doing that frequently. You should be reviewing that medication technique over time. You don't just do a one and done. It's really important that you look at that almost every time you have a patient come in, and particularly since we often don't see patients more than once or twice a year for a specific thing like COPD, but maybe more frequently as they get older and have more challenges. But that it really is important to review that, because that technique is really easy to lose quickly. How do you do the breath intake? How do you do the breath? Do you breathe all your air out first? Do you take a deep breath in? Do you hold your breath? Does your chamber whistle? Whistling is bad. I have people that are super excited. Oh, my chamber whistle. Like, oh, that's wrong. So there's all these little things that are not intuitive, I don't think, that are really important and are really crucial to making sure that medication gets all the way down into the lungs and does the work it's supposed to do.
Great, thank you.
Yeah, thank you.
That piece about the CPT code, I think, is really valuable for all of our members, because I I did not know that that was an option. And, I also have asthma, and I've had medication since I was 10 years old. And I can say that I had the same experience. It was like handed to me and my mom, and it was like, here you go, have fun. And I haven't had anyone review it since. And they always just
Wow. Yeah.
ask, they
Right.
say,
Yeah.
do you take your medication still? Well, yes, but there's never once been a provider who said, let's review it and make sure that you're using it.
Oh, that's
appropriately.
unfortunate. Yeah, that's right. So, I mean, I've had
Mhm.
patients, right? They'd say, so if you just ask the question, are you taking your medication? They're like, well, yeah, of course.
Yeah.
But they may not be, because they don't want to disappoint you, right? They don't
Right.
want you to think that they're not a good patient. So, again, this adherence rate, we often have patients that are not taking medications. I've had a lot of patients in pediatrics, at least, that I did the most work in, that the parents would say, oh yeah, absolutely, they take the medicine every day. And the kid would turn around and go, it's like, no, I don't. I haven't taken medicine for a long time. And the parents like, you're not supposed to say that, or they didn't know because they were thinking the 5-year-old could do their own medications, right? So it's really, really crucial. And I always say, if you're going to ask about medications, you need to say, what medications are you taking daily? Instead of saying, are you taking this, 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 and this? We also need to review, like, which inhaler do you think are you supposed to take every single day? Because I've had patients hold up their short-acting beta agonist and say, this is the medication I take every day, short-acting beta agonist, ProAir. And this is the medication I take only as needed, my Flovent, right? That's the opposite. It should be absolute opposite. Or they'll say, oh, I take a red inhaler. Well, which red inhaler do you take? Is that the ProAir or is that the Symbicort? What color do you consider your Alvesco? Is that red or is that brick? There's like all these different colors, but they're very close to red. So it's really, really important to have, I think, to have those inhaler posters that people can point at and say, this is the one I take every day, and this is the one I take as rescue or reliever. And then having them understand truly what medication that is. That's the medication I take every single day. Maybe you need to put a label on it. So there's a lot of review, and very, very important, because we can't expect our patients to be well controlled if we don't help them take their medication appropriately. It's much more challenging than just taking a pill.
I entirely agree. Yep. Wonderful. Well, I know we're at time, so I'll just share our closing slides. Thank you so much, Karla, for your wonderful, informative presentation. This has been really helpful, and I'm sure anyone who wasn't able to attend will find it equally powerful. Just so you guys know, we've got some upcoming work groups. We have a cardiac rehab work group on February 16th and a health equity work group on February 28th. And then we have our first work group in March will be March 15th. Our topic will be announced soon. You can register online. There's a link in the slides. And then that is it for today's work group. Thank you again, Karla. Thank you all for taking the time to join us today. We appreciate the conversation. If you have any questions, we will CC Karla on the follow-up email, so you can always follow up with her directly. Right. Thank you. Have a wonderful rest of your day, everyone.
Thanks so much. Bye.
Bye.